artery fluid. The central retinal artery is occluded. It is occluded. Most likely it is occluded where? Where it is occluded? It is occluded at the lamina tuberosa. At the lamina tuberosa or behind it. Or behind it. At the lamina tuberosa or behind it. So once it is occluded by thrombus or embolism. By thrombus or embolism. So we see the clinical thing first. Then I will discuss pathogenesis and other things. So clinically, once the patient comes to you, what he will tell you, what is happening. He will tell you that I have lost my vision. I have lost my vision. What is this classical symptom of central retinal artery occlusion? That is just sudden painless diminution of vision or loss of vision. That's loss. That is loss. What is the exact symptom? They will tell you that the lamp was there. I can't see it now. The flash of light has gone. Okay. So there are different blurring of vision. Some person will tell you curtain has fallen off my vision, or I am seeing black things. But in this case, it is so severe. The light, you are seeing a bulb. Now the patient will tell, I can't see it at all. It has switched off. It is not, the bulb is not shining at all. So if this symptom is there, you have to think of central retinal artery occlusion. You have to think of central retinal artery occlusion. Then once you have just 5 minutes to decide. How many? 5 minutes to decide. This is the real emergency in ophthalmology. One of the real emergencies in ophthalmology. So patient walks in and he is telling you that I have the lamp has it suddenly vanished from my eye, so I can't see it at all. So once he enters into your chamber, you have to see clearly, quickly the vision. You have to see the pupillary reaction. There may be a related afferent pupillary defect. You have to see the fundus. What you will see in the fundus? What you will see in the fundus? There will be pale. There will be pale fundus. There will be pale fundus. The macula will be given a red spot. What is called a cherry red spot. What is called a cherry red spot. Once there is a cherry red spot that is a pale, this is classical presentation of central retinal artery occlusion. So once this patient, and now you have seen that he has a gross diminution of vision, he has a afferent pupillary defect, and he has a classical cherry red spot of the fundus with a pale retina. Then we have to start the treatment. You have to start the treatment. What treatment you will do? What is the treatment guideline? You have to first decide, because the window of time in which you have to do the treatment is very small. Generally they say it is 1.5 hours. How much? Within 90 minutes. Within 90 minutes. You have to institute the therapy. You have to institute the therapy. If you cannot, maximum they say 4 hours. That means 240 minutes. How much? How much? 240 minutes. But if somebody comes of late also 20 or 24 hours, you can still attempt. But this 90 minutes is a window period. This is a window period. Or at max 4 hours. That is 240 minutes. So in which you can just reverse the vision. Because as you know, any neuronal tissue, the window period is very small. So retina is a neuronal tissue. Permanent damage means the vision is gone for life. So once we have this, then we tell the patient first thing we tell the patient to breathe in a bag. To breathe in a bag and inhale, exhale from that. Or if the bag is not there, you can tell him to just hold your arms like this Breathe out and breathe in. Breathe like this. You will tell him to close the two hands and tap on the mouth and nose and push the air out, exhale, then inhale. What happens in that? You are inhaling carbon dioxide. You are inhaling carbon dioxide. It's a vasodilator. It's a vasodilator. So this is the first thing. The next thing what you do? You will tell the patient, you will do the massage of the eyes. You will do the massage of the eyes with the 2 fingers. Once you will do with the massage with the 2 fingers, the idea is what? The massage, 2 things happen. The intraocular pressure becomes low. And number second, the thrombus which is lodged there, that can get dislodged in the peripheral vessel. So you continue this massage for some time. Till then you have to prepare for paracentesis. You have to do the paracentesis. Paracentesis you can do with the needle or the slitter, or you can do with the theatre if available. You have to just enter into the anterior chamber and remove some aqueous, that's it. Then you have some other modes. So first thing is inhalation, exhalation with the carbon dioxide or in the bag or with the hands. Then number second thing is the massage. Third thing is the paracentesis. And fourth thing you can give them some vasodilators. You can give some sublingual isosorbide, sublingual, or you can give a nitroglycerin patch, or you can give an IV intravenous istazolamide, or you can give intravenous pentoxifylline. So these are all causes of vasodilatation. So if you feel after doing these for 10-15 minutes, if you think that patient is improving, then you can just check the vision, check the pupillary reaction, check the fundus. If not, then you can repeat the paracentesis. So this is the emergency management of this. Then once we have done this, we have to see the patient's general systemic examination. Why? Because these patients have cardiovascular disease. They have cardiovascular disease. Then they can have some vasculitis. So you have to see that. Suppose you see a radial pulse. You have to see whether there is fibrillation or there is the 2 pulses are different in one arm or in the other arm, like a Kaplan-Meier disease. Or you can report the blood pressure. Then you can do a carotid pulse, whether the carotid pulse is diminished or not. Or the temporal artery angiitis. You can see whether the temporal artery is thickened or not. So these are the basic things what we have to do. So here, if you can see, there is a jelly red spot, and there is pale area around. Why there is a jelly red spot? Because the coli, it is so thin that the coli and the choroidal vessels, they shine through this thin hole. And why there is pale? Because there is ischemia. There is a ischemia and edema around. So this was the emergency management. Then you have very important one sign called cattle trucking. What's cattle trucking? It's break in the blood column. There's multiple segments of the blood column. It is thought to be the pathognomic of central medullary artery. One is and other is jelly red spot. So once the patient goes after suppose 1 week or 1 month or 3 months, what will happen? This paleness will go, but vision will not be recovered. Then the optic nerve can become atrophic, what's called optic atrophy. Okay. Then you can have the narrowing of the vessels or the sheathing of the vessel. So optic atrophy, otherwise the front looks normal, but without any function. So it has lost its photoreceptor. The function of there is total damage to the photoreceptor. So this was the findings. Then if we talk about the causes, if we talk about the causes now. Symptoms and signs I have told you, emergency management I have told you. What are the causes? So causes are mainly, it can have two types of causes. One is thrombosis and other is embolism. Thrombosis, as you know, diabetes, hypertension, and hyperlipidemia. They are the causes. What are responsible for the atherosclerosis? Then we can have a hypercoagulable state in the blood. Hypercoagulable state. Like we have polycythemia. We can have polycythemia. We can have coagulation, anticoagulant deficiency. Anticoagulant like protein C deficiency or protein S deficiency. We can have some in the young patients. In the young patients, you can have oral contraceptive use. But oral contraceptive use. As important in young is hyperhomocysteine. High levels of homocysteine in the blood. That can be genetic or that can be nutritional deficiency, right? Because the homocysteine is metabolized dependent upon vitamin 6 and vitamin 12, B6 and B12. So once the nutritional deficiency, the metabolism of homocysteine is impaired, and it induces what? It induces the stickiness of the RBCs or platelets or fibrillin, and it can cause thrombosis. That is the mechanism how homocysteine can cause central retinal artery occlusion. So in the young, it has been seen that this is a very important factor in the Indian population. And in the Western population, there is vasculitis, sarcoidosis, so vasculitis is one more feature, especially the giant temporal arteries. Giant temporal arteries. As well, you can have other like rheumatoid arthritis, then sarcoidosis, so many autoimmune diseases which can cause vasculitis, that can cause central retinal artery occlusion. But these are the causes of central retinal artery occlusion. Then you can have one more, I forgot to tell you, the leukemia, the leukemia and the lymphoma. One more is which is last the pandemic. Again, I have to talk about the pandemic of coronavirus. That caused the hypercoagulable state. And the hypercoagulable state is responsible for thrombosis. So that also can cause central retinal artery occlusion. One more thing is that if there is a increase in the intraocular pressure, that's called glaucoma. Increase in the intraocular pressure, which causes a compression of the artery, or which can decrease the blood flow to the eye, or there is an increase in the intraorbital pressure. This is if there is an increase in the intraorbital pressure by due to any reason, that can compress the retinal artery directly and cause the central retinal artery occlusion. So these are some of the causes of the central retinal artery occlusion. Then we have the pathogens I have talked about. Thrombotic, you know from your knowledge, the atherosclerosis is a very important thing of thrombosis. Embolism, you know, where from the embolism come? It can come from the heart. That's the granular heart defects. Maybe it can come from the heart, or it can come from the carotids. These are the two important, carotids and the heart. And once there is an embolism from the heart, like mitral valve, aortic valve, atrial fibrillation, they will all predispose to embolism, or even endocarditis. Even endocarditis, you can have infective vegetations going to the artery. They can also cause central retinal artery occlusion. Then we have the carotid we have a thrombus. That's why we should calculate it and see whether the pulse is low or absent there. So there can be a carotid artery and thrombus there, which can get dislodged and which can go into the eye. Then third thing is what are the different types of emboli? What are the different types of emboli? We can have cholesterol emboli. We can have cholesterol emboli, which are very common. That's around 75%. How much? 75% of the emboli are cholesterol. Then we can have calcific emboli. Then we can have fat or amniotic fluid emboli. Then we can have the fibrin lactic type of occlusion, like atherosclerosis type of occlusion. Because the fibrin and lactic, they form the atherosclerotic cloud, which can cause occlusion. So these are the different types. Once there is the block of the central retinal artery, once there is the block of the what will happen? There will be ischemia. Once there will be ischemia, because retina is mainly supplied by central retinal artery. Some of it, 1, 2 or 3, 4 years, they are supplied with choroid also. But choroid is not sufficient. So once there is a central retinal artery occlusion, it leads to the vision loss. So once there is occlusion, what will happen? Once there is occlusion, what will happen? There will be hypoxia. Once there is a hypoxia, what will happen? Mediators will be released, which will cause permeability change in the vessels. Okay, once there is a permeability, there will be a release of the edema fluid into the retina, or there will be stasis of the exoplasm of the nerves. There will be stasis, nerves will not be, so there will be edema in the retina, which can cause opacification of retina. Once there is opacification of retina, that can cause what? Damage to the photoreceptor. Because ischemia in itself, because eye is a very metabolically active structure. Once there is a blood occlusion, there is the arterial occlusion, that will cause ischemia, that will cause malfunction of the photoreceptors. Then most important is, once we deal with this central retinal artery occlusion, we have to send it to the general physician or an internist, because this cause is mostly systemic. That's more cause is mostly systemic. Why? Why we should? First, we should address the health of the individual. Number second, we should try to save the other eye. This thing can happen with the other eye, and you can just sensitize the person also. How you can avoid the other eye? You can tell the patient, if you feel temporary loss of vision, what's called amaurosis fugax. What's called amaurosis fugax. What's called amaurosis fugax. It's like of a temporary stroke. It's like of a temporary stroke. What we call in the neurology or in brain, we call transient ischemic attack. TIA. TIA. It's a sort of a TIA. So temporary loss of vision, recovery. So that means it's already predisposition for the second eye. Is it? Predisposition to the second eye. Then you can tell something if you lose a vision or you see the flashing of a lamp goes, you must start the massage of massage of the eye. Personal massage. Patient will do it himself if it happens to the second eye. So these are the important things in this. Then if you have now to see the investigation, if we have to see the investigation, what investigation do you do? Most important is fluorescein and geographic. Most important is fluorescein and geographic. What happens to fluorescein and geographic? No, we inject the dye and we see the retinal vasculature. That's understood. But what happens in central retinal artery occlusion? There is delayed filling. There is a delayed filling. Normally the arm retina time. Normally the arm retina time is how much? 10 seconds. How much? 10 seconds. How much are you? So normally the time is 10 seconds. How much? It is only 10 seconds. So if it is delayed, like this 15 seconds, 20 seconds or 25 or 30 seconds, that means that the retinal artery, there is some occlusion to the retinal artery. This is the most important thing. The arm retina time is prolonged. That means arm retinal diameter is wrong. Then you can have other investigations. What other investigations can? You can have OCT. You can have OCT, optical coherence tomography, which will show a hyperreflectivity of the inner retina and hyperreflectivity of the outer retina. What is that research? The only clinical thing is fluorescein angiometry. Then you have another ERG, which shows a B wave reduction, because B wave is from the bipolar cells. A wave is the negative wave, that's from the rods and bones. Okay. So ERG, suppose this is the A wave, this is the A wave, and this is B wave. So there is a reduction in the B wave. Reduction in the B wave means the bipolar cells are not producing the normal potential. They will select it. So this is a sort of fluorescein angiography. So here, basically the idea is once you inject, you have to take routine photographs. You have to take routine photographs. Then you have to calculate the time from the arm to the retina. So if it's prolonged, so normally within 10 seconds it should come into the retina. Normally what happens? It goes first to the choroid, ciliary circulation. Then once it goes to the ciliary circulation, then it will come in the central retinal artery. Then there is the arteriovenous phase. Then there is the venous phase. So there is a delay in the arterial phase. And we see these white things coming in the vascular system. So this means this is coming in the central retinal artery branch. And this background is in the choroid. The branching background is in the choroid. That is the ciliary circulation. So the most important thing in fluorescein angiography is the delay in the transit time. And number second, we have the most important is if you have cilioretinal artery. If you have cilioretinal artery, suppose cilioretinal artery comes from the ciliary circulation. That comes from the choroid. Suppose you have central retinal artery and there is an entire cilioretinal artery. That will preserve some part of the vision. Okay? That can preserve because that is the branch of the ciliary circulation, not the central retinal artery. So there are some other treatments also. One is the hyperbaric oxygen. One is the hyperbaric oxygen. So you are giving 95% oxygen with 5% carbon dioxide. There is one more you can do a YAG thrombectomy. You can see, if you can see the thrombus on the central retinal artery head, on the lamina tuberosa, you can hit it directly with the laser and break it. But these are all investigations, not practical. Then you can give one more treatment is high dose steroids. When you will give? One is vasculitis, like temporal arteritis. The temporal arteritis, the treatment is high dose intravascular steroids. High dose intravascular steroids. So previously we were believing that the most important site where the obstruction was taking place was the lamina tuberosa, where from the retinal arteries, central retinal arteries coming. But now it is bleeding because once the central retinal artery is a branch of what? Ophthalmic artery. Once it enters the meninges, once it enters the meninges and optic nerve, that is considered to be the thinnest area. Thinnest area. The most of the emboli they say are lodged there. Okay? So, number one site for obstruction is where the central retinal artery enters the meninges. Number second is the lamina tuberosa. Lamina tuberosa. One more thing I want to clear to you, that is giant cell arteritis. It can also cause central retinal artery occlusion. How you can distinguish that from this? Because in that, the choroidal circulation, the ciliary circulation will be also affected. Because the thrombus is lodged where the main ciliary trunk, including the central retinal artery, will be included. So there will be very delayed dye coming in the choroid, the ciliary circulation. So delayed filling of the ciliary circulation is part of what? Giant cell arteries. And delayed filling of retinal circulation is a thrombus which is always in the central retinal artery. So this was about the central retinal artery occlusion. Now I will take the veins occlusion. Next. If anybody has any question regarding this, you can tell me. So there are some more types, just I want to enumerate. One is the transient CRP. Transient CRP. That means this impulse will come and go. Temporary loss of vision. Or there is a vasospasm. There is a vasospasm of the central retinal artery with thrombus, and the pallidum secretes serotonin. That causes the vasospasm temporarily. We can sleep. So there will be loss of vision, it will come within few seconds, within few minutes automatically. This is called transient CRU. Then you can have non-arthritic CRU, which is the most common. Non-arthritic CRU. Then what I have been describing, that's non-arthritic CRU. Then you have the CRU. CRU with celoretinal. Non-arthritic CRU with some celoretinal vasculature, which will preserve some part of it. Then we have the last is the arthritic. Arthritic means giant cell arthritis, temporal artery, that is due to vasculitis. That is due to vasculitis. So these are the four types of retinal artery occlusion. So now we go to the veins occlusion. So veins occlusions are again they cause a decrease in vision. So veins, we have one major cause of decrease in vision is central retinal vein occlusion, CRVO. It is divided into two, ischemic and non-ischemic. It is divided into two, non-ischemic and ischemic. Then we can have branch retinal vein occlusion. Then we can have branch retinal vein occlusion. Then we can have hemicentral vein occlusion, in which half of the retina is obstructed. Same way we have in arterial occlusions also. We can have branch retinal artery occlusion. We can have branch retinal artery occlusion. We can have hemicentral retinal artery occlusion. So in retinal artery occlusions also that's the case. So veins occlusion, what the patient will come? He will come, I have decrease in the vision. I have decrease in the vision. So once he has decrease in the vision, he is an elderly man, like 50 or 60. Then once he lands in the OPD, in the outpatient department, then once we see the pupillary reaction. We see the pupillary reaction. So pupillary reaction can be sluggish or it can be normal. More the sluggish, more the chances of ischemia. So ischemia, more the RAP. Non-ischemic, less the RAP. Vision loss, more it is ischemic. Vision loss less, it is non-ischemic. Okay. Then we have this pattern. This is called a tomato splash pattern. Tomato splash pattern. And there are multiple hemorrhages all around the fundus. There are multiple hemorrhages all around the fundus. And then we have the hemorrhage should be present in all four quadrants. They should be present in all four quadrants. And they can be superficial or they can be deep. Superficial or in the nerve fiber area. Because nerve fiber is towards the vitreous. It will cause plane-shaped hemorrhage. It will cause plane-shaped hemorrhage. Deep will cause dot-shaped hemorrhage. So more the deep hemorrhage, more chances of ischemia. Then we have one more portal wool spots. One more is they are more present in the ischemia. So deep hemorrhage, portal wool spots, the loss of vision and the RAPD. These are the four cardinal sites of ischemic CRU. Okay. So one is ischemic or non-ischemic CRU. What you will do? You will first make a diagnosis of ischemic or non-ischemic CRU. How do you do the diagnosis? You will do on an angiography. You will do an angiography. What will be the difference in the angiography between ischemic and non-ischemic? In non-ischemic, there will be no capillary drop. In non-ischemic, there will be no capillary drop. In ischemia, there will be capillary drop. Angiogram will be black. Angiogram will be black. Suppose this angiogram, it appears to be that capillaries are well perfused. There is no blackness. Okay, there is no blackness there, gross blackness. So if there are black areas where the capillaries are absent, it goes more in favor of ischemic CRVO, which has a bad prognosis. Suppose now I tell you, what is the causes of the CRVO? Whatever the signs from, you have to go out.
Yes.
Simple. All these things, diabetes, hypertension, hyperlipidemia, hypercoagulable state, polycythemia, okay, protein C deficiency, protein S deficiency, glaucoma is a very important cause of vein occlusion. High the intraocular pressure, it will press on the vein. Okay, it will cause more obstruction. What is the leukemia, lymphomas? Here I want to clear one thing. Why we have heart? Suppose you have diabetes, hypertension, and hyperlipidemia. They are considered to be arterial, atherosclerosis type of disease. How they can cause vein occlusion? No. So hypertension, diabetes, and atherosclerosis or hyperlipidemia is causes atherosclerosis of arteries. How it will cause vein occlusion? Do you understand me? Suppose hypercoagulable state, protein C deficiency, protein S deficiency, or polycythemia, leukemia, it will cause what? It will cause thrombosis in the veins also, stagnation in the veins also. But how deep you cause hypertension? Anybody can tell me? He will have to deal with me.
So compress.
Pressure. What pressure? You get a better you get a hormone. No. Huh? Angiogenesis. No. How can you do?
Compress क्योंकि वो पैरल प्रैक्टिकल
How can you come over? हाँ खड़े होकर बोलो मुझे बेटा. Hypercoagulation to be where? Huh? That's what I talk of diabetes and hypertension. Hypercoagulation. We will cause that. But how the atherosclerosis will be? Anybody in the girls? Huh? Yes, that is the reason. You are absolutely right. So once these arteries and veins from the lamina propria, there is a atherosclerosis in that artery, which gets from the vein, which will decrease its lumen, Okay, that may cause the thrombosis. That is how these three arterial causes, hypertension, diabetes, and hyperlipidemia, cause veins thrombus. So normally in the veins thrombus, what will happen? Who has told the answer? Answer किसने बोला? आपका नाम क्या है? हाँ? Iltizam. You can have a cup of tea with me. If you like. Don't be shy. It's normal. You can have. There is no problem. So once we have thrombosis in the veins, what will happen? It will create a back pressure. There will be increased capillary pressure, which will cause release of the permeability of the vascular wall, which will cause blood in the retina, which will leakage of the vascular wall, and because the blood cells get leaked out, there will be hemorrhage, there will be fluid loss, which will cause accidents. Okay. So even there is a stagnation of the fluid in the nerve, which will cause waterlogged spots. So other thing in addition to this tomato splash appearance, we have the what's called the tortuosity of the veins. What? Tortuosity of the veins will be more in case of veins. आपकी वो दिखाओ टेबल है ना रोड में ये लास्ट है so you just take pic of this or use a mobile phone to take pic of this so this differentiates the non-ischemic from the ischemic okay so non-ischemic is more common and ischemic is less common less frequent vision losses paleness, both pupil is normal in non-ischemic almost, or it can be slightly affected, or it can be slightly affected. In case of ischemic, it will be a rapid. What rapid will mean related to the pupillary effect. So pupil will be sluggish, very sluggish in ischemic. Then we have the retinal hemorrhage, which will be deep, hemorrhage will be more common in what? In the ischemic type of CRE. Then waterlogged spots will be more common. The macular things may be very early, like the macular edema. Like the macular edema will be very early in case of ischemic, and it will be more marked. It will be more marked. Then the disease swelling can be more severe in ischemic. So FFA, I told you, there will be capillary dropout. Then the complications are more in case of ischemic. There is more in case of ischemic. Why there are more complications in ischemic? Because in ischemia, what happens is once there is ischemia, the retina releases VEGF. It releases VEGF, vascular endothelial growth factor. Once vascular endothelial growth factor is released, it causes what? It causes angiogenesis. Once angiogenesis happens, what it will cause? It will cause more hemorrhage. It will cause more hemorrhage. Okay, it can cause more ischemia. Okay. So it is again causing more ischemia and more VEGF is released. More neovascularization occurs. Okay? And once there is more vascularization, there is more VEGF released. This VEGF can go through the vitreous into the anterior segment, in the iris. It is called also neovascularization of the iris. And once you call neovascularization of the iris, it can block the trabecular vessel. It will be a neovascularization of the ankle. It can go under to cyclotranslation. That can block the ankle. And it can lead to neovascular glaucoma. It's a very dangerous type of glaucoma. Refractory to treatment, which does not respond to any treatment. Okay? So once there is neovascularization of the iris, especially in the pupil, especially around the pupil. Around the pupil, you have to see the patient undilated because you should not miss. Once you see a neovascularization of the iris, what you will do? There is one form of treatment in that called pan-retinal photocoagulation. Pan-retinal photocoagulation, PRP. What's called? This is, you can see the new vessels here. These are the new vessels. These are the iris around the pupil. So once you see anti-eye, it's called anti-eye, neovascularization of the iris. So once you see this, you will go for pan-retinal photocoagulation. That is done in 4 quadrants: supratemporal, infratemporal, supranasal, infranasal, leaving the macular area and disc. Okay, once you do all these 4 quadrants, what happens? They become anoxic. And VEGF is not released. Okay, from hypoxic they become anoxic. Their photoreceptors are destroyed, so they don't have oxygen demand. And one more important is called NVD. What's called? Neovascularization of the discs. NVD. Other is the NVE. neovascularization elsewhere. First is on this and other is the other way of the retina. So neovascularization of the disc is small blood vessels, tiny blood vessels which are fibrous type, and elsewhere they are the periphery of the retina happening neovascularization. Again, that is an indication for pan-retinal photocoagulation. So if you have neovascularization of the disc or neovascularization of the elsewhere, or you have the NVR, you have to go for pan-retinal photocoagulation. So now I am talking about the cause of the vision loss. What is the cause of vision loss? How the vision loss occurs in this retinal vein occlusion? Anybody can tell me? Because I told you there is a back pressure, then there is release of this, there is edema in the retina. There is an edema in the retina. What will happen with that? Edema of the macula. Edema of the macula, what's called cystoid macular edema. That's number one cause of vision loss in what? Vein occlusions. What's that called? Cystoid macular edema. Cystoid. How we diagnose that? The macula becomes edematous. Suppose normally the macular thickness is 250 micron. How much? 250 or 230. So it will lift up like this. It will become this much. So there is a macular edema. Suppose it's 400, 500 micron. So you can say that the macular edema has occurred. You show an image of the macular. This is the macular edema. This is a OCT picture. Normally this is a depression, foveal depression here. This is a foveal depression. This is like this. So it has lifted up. This is the fluid space. This black of the fluid space. You can take pic of this. All can take pic of this. This is the OCT is the main investigation in vein occlusion. OCT is the main investigation in, as a fluorescent angiography is the main investigation in arterial occlusions, and OCT is the main investigation in vein occlusion. Because we want to reverse the vision loss. We want to reverse the vision loss. And how we can reverse the vision loss? What are the treatments for this edema? We give anti-VEGF. We give anti-VEGF because there is VEGF is the problem. So we give anti-VEGF. What are the names of the anti-VEGF? Avastin. One is Avastin. That's an off-label use. That's not recommended for eye. That's recommended for something else, but we can use in the eye. That is it. Brocizumab. That's it. Brocizumab. Then you have one more is ranizumab. The trade name is Lucentis. Lucentis is the ranizumab. Then we have one more what's called Eylea. Aflibercept. Aflibercept. That's no more drug is given in this. How they are given? They are given just by injection through the pars plana. They are given by injection, but they have to be repeated. They have to be repeated. Suppose you have given one injection, the patient is responding, then you can give 1 month after again. Suppose patient, if by one injection patient is responded, macula has become normal, then you can stop it. Suppose patient has not responded, 1 month after you still see somebody, or you can give more. Or third month you can do one more injection like that. So these injections are very costly. Suppose the Eylea is around 20,000-30,000 rupees injection, like that. So one more treatment is intravitreal steroids. Intravitreal steroids. I forgot to tell you in arterial occlusion, there is also given intravitreal steroids. I told you it's systemic steroids. Systemic steroids. Like Janssen or try to review systemic steroids, not intravitreal. So intravitreal steroids are given in this. Okay? Can be given. Generally we give anti-VEGF. We give anti-VEGF. But instead of anti-VEGF, because anti-VEGF has what? It has some contraindications. What contraindications? stroke. If somebody is myocardial infarction, okay. If somebody has a renal azotemia, so these are the contraindications to the antivenom. So in that you can give an intravitreal steroid. What type of intravitreal steroid are we giving? We give implants. One implant is Ozurdex. Ozurdex is a dexamethasone implant, which can be given 3 months. Okay, we can give over 1 year like that. That releases the steroid slowly in the vitreous. What is the drawback of steroid implants? They cause cataract. They cause cataract. Suppose somebody has now lens in the eye. So in that case, it can be safely given. So two classes of drugs. One is anti-VEGF and other is steroids. So these are the mainstay of the treatment for the venous occlusions. So anti-VEGF we have 3. One is Avastin, what's called Brucizumab. Other is the Lucentis, which is called Ranibizumab. Third is the Eylea, which is called Aflibercept. Okay. Then we have the steroids, and we have a dexamethasone implant by the name of Ozurdex, which is an implant which is just directed through the pars plana into the vitreous. Then we have one more option that's called chorioretinal anastomosis. It's done in a non-ischemic CRVO. So by the laser, we do an anastomosis between choroid and the venous system of the retina. This is just investigation, practically not that. Then we have the vitrectomy. One is the optic neurotomy, or you have optic neurotomy means what? You have to cut the optic nerve like that. You will release the pressure on the vein. Again, this is investigation. Anything else, madam? It is over. It's over. Just why you are in the last one? So, one thing I forgot to tell you, one cause of vision loss is in the venous occlusion is macular edema. What are the other causes of vision loss? Oh, Mr. What is the cause of vision loss? One is the cystoid macular edema. Any other cause? Huh? How do you want to tell me? Hemorrhage. No. What is hemorrhage? Yes. You are right. What causes hemorrhage? What happens to the hemorrhage? Hemorrhage is toxic to the photoreceptors. It is what's called hemosiderin type. Suppose there is a hemorrhage in the macula, it will destroy the photoreceptors. So any other thing? One is macular edema, other is blood is toxic to the photoreceptors. Third, sometimes what happens once the CRVO happens, the photoreceptors are detached from the RP. That is the third mechanism of vision loss. Suppose we have macular edema, we have given anti-VEGF, macula has no problem, but vision has not recovered because there is permanent damage to the photoreceptors. That's why in that case, these are the causes of what? These are the causes of the vision loss. I think that's enough for you.